Hello.
Welcome, sir. Good evening, sir.
Good evening,
Hello,
sir.
hello, sir. Welcome, sir.
Good
Yeah,
evening, sir.
yeah. Now we
Welcome,
have
sir.
there's a minimum. There's always a bench line to start in, depending on number that's offering the course. And what I can see here is about 88 persons online. Now it is 6:40. I don't know. The data I have is that you flow up to 400 and something. I'm not seeking an opinion because it's a democratic kind of thing. Do we give another 5 minutes or do we start?
I think we can give them 5 minutes, Prof.
Yes, Prof. 5 minutes is okay, sir.
So, which means once it's 6:45, I will hit the ground.
Yes, sir.
All right. So when we start, every person will move the Good evening, friends, brothers and sisters.
Good evening, sir.
Good evening, sir.
Okay.
Good evening, sir.
I believe the number has come up a bit, so we can start. Others send text to your friends to join, because they find out that even me myself, many a time I'll be waiting for a one online discussion. Before you know it, I forget. If not for your group leader that keep probing me, I might be waiting for it. So age is coming too. So okay, I would advise we all put our phone on or our system on mute so that there won't be interferences. This evening, in the next 2 hours or so, we'll be looking at family planning and reproductive health. Everything we're going to discuss will be revolving on family planning. Otherwise, look at population dynamics. You get what I mean? How does the ecosystem adjust to make sure that every sapiens, in this instance human, coexist and coexist healthily? That is all the essence of this discussion. The dynamics of population. How do we maintain equilibrium in the ecosystem so that all of us can exist and exist well as regards to population? How do we balance that population? How do we keep that population healthy? See, you are all senior men and women, and we are no longer talking to medical students or university students. We're talking to people who have gone through the nitty-gritty of the first degree and now thinking beyond just their nose. So anything we're discussing, don't take it as a joke or just let me go and pass my exam. You just think in the manner that it will expand their reasoning power in the way to handle things as it comes to you as you. So in summary, in one or two sentences, I said everything we're going to discuss, which is under family planning and reproductive health, it boils around the dynamics of population. How do we stabilize it? What do we want to make out of it? To make sure that all the Homo sapiens in that ecosystem, in this ecosystem called Nigeria, and the world at large, coexist healthily and live healthily. My name is Oranu Emmanuel. I'm for the Department of Obstetrics and Gynecology, University of Port Harcourt. We're going to look at modern contraceptives, the services that are rendered, the modern one. There is a room letter in these 2 hours for us to discuss also the traditional contraceptives in order for us to have good judgments and justify why modern is modern and traditional is traditional. And also because some of those traditionals are still in vogue, we need to mention them for you to use your mind to either discharge or accept them as you now go further in your life, because some of you will end up in a very serious position decision-making position. So as you are making that decision, you put things together. We will also look at these modern services, modern contraceptive services we are talking about. How do we go implementing them? How do we provide these services? Looking at accessibility and affordability in particular. How accessible, how affordable, because that's the bottom line. We will look at emergency contraceptives, post-abortion care, and post-abortion contraceptives. We'll look at the social marketing of family planning services. We'll look at all this in the first section. Then when we enter the second section, we'll look at the other topics we'll look at. I'll bring it to point. It might not follow the pattern in giving to you, but at the same time, that's how I've chosen to arrange my own. Whether A to Z or Z to A, we get what we want. That, I think, is the important thing. Please, as I go, anytime you are not hearing me well or any issue, you are free to draw my attention. It's an adult education. So, at the end of this discussion, the objective listed here, you are seeing them. The summary, if you look at all of them, something is striking. That thing that is striking is that not much is required of you at the end of the day in terms of testing your ability of what has been taught. Simple things are required of you. Can you mention the side effects? Just mention them. For example, the nitty-gritty of how it comes about, why is it like that, and all the rest is secondary. The objectives are primary things. If you achieve the objectives as listed here, you are home and done. Because we follow the pattern in asking our questions. It mustn't be mentioned. It might not say list. It might not say enumerate. What are the possible side effects the sentence is saying? Use A or B to say it is sentence. So it's simple requirements. Now, moving it at a higher reasoning is now your personal desire, your personal effort, how you want it done. So it's listed here. At the end of the day, these are the simple things we needed you to do. And these are the simple things we're going to discuss rather. Now, if you look at that topic that was said before, family planning and reproductive health, there are basic requirements. It's divided into two. All the topics we have listed, plus the one you're going to see later, are listed under two basic divisions. The basic and applied. This basic is the basic things I have been teaching medical students. You should know them as basic so that when you are talking, you are well grounded. Then we will come to application of all these basics. How are these in that basis? We look at introduction and history, the family planning methods and side effects, as we have said, modern contraceptives, services rendered, especially counseling. We look at them under basic as we have been talking to medical students. Then, when you now look at applied, what are the interventions taken? These methods we have spoken in the basis. How does it affect reducing maternal and newborn mortality and morbidity? How does it affect it? The health of the mother and the baby? How does it affect their getting sick and possibly dying? It's an application. We will look at it. And that is captured in, is it accessible? the contraceptive services, are they available? If they are available, are they accessible? Because these are two different things. It might be available, but people might not know that it's there. Therefore, they might not access it. They might not go to apply for it or make an uptake on them. Meanwhile, it's available. As simple as what I'm telling you is, they might not even know that some of them are there and it's even free. So how do we now apply social marketing to this accessibility and availability? These two slides, as I've said, is a broad division of the topics we're going to discuss. The methods, the side effects, counseling, those are basic things, and they will be done. Then we talk about now, how are these methods we have seen, we have provided, how does it now reduce to naira and kobo? That is to say, how is it reduced to basis? Not just talking theory. You have put contraception on the woman's hand or inside her vagina and so what. At your level now, that's why I'm emphasizing it. This application, this applied one, is where you will even be more interested. Yes, the other one is basic, and in any training, there are things that are basic. If you don't know it, you shouldn't even talk about that topic. You shouldn't even enter up. So that one should be given. The one that PRH should come on is, have you understood how this thing now translates to survivor of the mother, survivor of the baby? That is the main issue. And that is where we are going to go. So we will introduce our topic. Now we are starting. All the things we have said this far is laying base, laying foundation for us to appreciate what we are going to do from now on. And I ask, are you hearing me? And are you understanding what I'm saying?
Yes.
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 Yes, sir.
Yes.
So,
Yeah, you, sir.
so I'm
Yes, we are
going on.
hearing you, sir.
Okay.
Carry
Thank
on.
you.
Yes, sir.
Thank you. Mute your mic again. Let's move on. So in introducing the topics for today, which we have laid the foundation, family planning, we have said for the ecosystem to exist. And that existing means that there should be the ecosystem to be exist and the equilibrium maintained. And for it to be maintained, there must be spacing of children. There must be limitation of children. So spacing will now mean what? Sorry, I just read what is written on the chart. Spacing will now mean the gap between one child and other. One limitation is when you say, I have 3 and I want to stop. I don't want any child again. Or I have 10 and I don't want any child again after this 10. That you are limiting the number of children you have. Or when you, okay, I needed 4 or I needed 3, but in between one and the other, I should rest for 2 or 3 years. That is spacing. So the services rendered to a couple to help them achieve and space the number of children they so desire, especially through modern contraception, is all we're talking about family planning. And that's why I took time to explain spacing and delimitation. Spacing, gap between one child and the other, or stopping to have children. So these services will render to couples to help them make sure they space their children or achieve the number they wanted through modern contraception is all what family planning is all about. And that is what contraception does. In the other hand, reproductive health is a state of physical or psychological well-being and not mere the absence of disease as it relates to reproductive health. And reproductive health components. Remember that in my topic, if you remember the first slide I showed, I said family planning and reproductive health as the topic, which we have explained so much before now. We have explained so much before now for you to understand. And we are saying now that that reproductive component, family planning and reproductive health, the components are preconception care, antenatal care, postnatal care, and it's going in sequence. It's after preconception care. For example, a secular, we give her advice on when to take in, or a diabetic patient that she should control her diabetes to be normal before she takes in. That's preconception care. Then caregiving when they're pregnant, antenatal care, and caregiving after delivery, which is postnatal care. Then family planning, which we offer them, and abortion services when they have miscarriages. These are the pillars or components of reproductive health. A well-formulated family planning interventions guarantees health of the mother and the baby, the family, and the nation. And that's why we take it seriously, because once it's gotten right, every other thing will follow. We look at the history of family planning. It didn't start today. It started as far back as 16th century or even before. But officially, family planning started in 1936. That time is called sex hygiene or birth regulation. Margaret Sanger, an American nurse, is reputed or known as the mother of family planning. So this is a part of the history. And we know that contraceptive services in history dates to camels and stone to now modern contraception. Those days, there's no modern contraceptive services. So, and these Arabs, they carry their camels across the desert. And you and I know, if you have not seen camel before, we see them in pictures and see heavy loads they carry. And then the wisdom of the owners, they felt that this camel cannot carry this load and now carry pregnancy, they can't cope. So during the journey, before the journey starts, they use cobble, stones, to block the coital area so that they don't mate and become pregnant. That's a kind of barrier contraception in history. That's how we now know that you can even use inert objects to block the coital region in order to prevent sperm from going in. And then there won't be any conception. It's part of the day. However, in Bible, in the book of Genesis, we are commanded by God himself, go into the world, multiply and fill the earth. I said stone, cobblestone to block. Somebody asked a question and I'm answering it. So I find out that you use stone. The area blocked is the coital area. That is to say, for example, a modern time, you can say you can say using stone to block vagina or to put into the uterus. The modern one now, for example, is the lupus loop, the inert contraceptive product which you put inside the uterus to prevent conception. So stone is put inside the vagina of the, just take it like that, so I understand what I'm saying, into the vagina of the camel, so that there won't be mating, that there won't be intercourse and then conception. So in the book of Genesis, also in history, one of the rich histories of contraception is that we were commanded by God to go into the world, multiply and fill the earth. If you pick your good in Bible, you go to book of Genesis, I've forgotten, I think chapter 10, either 13 or something like that, I think so. But project can be short. I'm very sure it's book of Genesis. God commanded us to go into the world, multiply and fill the earth. Now, that commandment is in two phrases. Because our God is wise. The omnipotent, omniscient God is wise and gave us a pinch of his wisdom. And say, go into the world, multiply and fill the earth, comma, conquer the earth and take dominion, full stop. So there are two phrases there. I won't go into this thing now. I would like you to remind me before we close this quotation and its misuse in this country today, and in many countries, especially the developing countries. Please don't forget. Group leader, if every person forget, don't forget, I'm giving you personally as an assignment that before I wind up, if I didn't revisit this thing, because I want us to move ahead first, revisit, remind me of God's commandment in Genesis that we should go into the world, multiply and fill the earth, and take dominion. Conquer the earth and take dominion. They gave us two assignments. One is that we should go into the world, multiply and fill the earth. Two, that we should conquer the earth and take dominion. And remind me so that we explain it as it relates to this topic, which is very, very crucial. Also, in the history of contraceptive services, one cannot overemphasize, overappreciate the effort of non-governmental organizations. The non-governmental organization has played a very big role in the success story of family planning. I don't know of other countries, but I know of Nigeria. I'm a living witness. I will come to that again. Now, what are the methods of family planning? What are the methods we have? There are various types. We have hormonal and non-hormonal, if divided into two broad groups. Many of them are hormonal, some of them are hormonal, some of them are non-hormonal. Now, these two broad groups, I use it to now emphasize the hormonal because they have the same characteristics. When somebody asks you, for example, what are the side effects of oral contraceptive pills, and you have read it, and you did not read the side effects of implants, which is also hormonal contraceptive, or you did not read or remember the injectable, the side effects, I am telling you now that all hormonal contraceptives is the same side effect. The same. So whether they ask you side effect of implant to implant and jade, or side effect of oral contraceptive pill, or side effect of injectable contraceptives, is the same answer. And that answer is also same. So that's why I first started by saying there are the modern contraceptive there are types, and that types can be broken into two broad groups, which is non-hormonal and hormonal, just to capture the effect that all the side effects are the same. Their mechanism of action is the same for this all hormonal. As we can see as we go. I say it now because I won't go to mention all the side effects again or mechanism of action exactly for all of them, because it will be a waste of our time. We have captured it that in side effects, anytime I mention hormonal contraception, is the same side effect I will say in one shoot. And it's the same mechanism of action I will say in one shoot. If we use implants, for example, implants, the one insert in the arm, we can say that broadly we have two types. There are other types, but the common types world over is either Jadel or Implanon. They are long-acting, that is to say, they last in years. Anyone that lasts in years is long-acting, just like Jadel, Implanon, hormonal intrauterine device that lasts about 3 years. So Jadel lasts for have 2 capsules and lasts for about 5 years. And Implanon have only 1 capsule and lasts for about 3 years of protection. It has progestogen at its component, which is hormone, and the efficacy is high, meaning that the chance of failing while on this implant is almost not there. I didn't say it's not there. It can happen, but the chances as it tends to 0, because the efficacy is almost 99.95%. 99.95%. So 0.05. So it's almost not there. If one is very highly efficacious and is placed on the inner border or medial border of the less dominant arm. Since most people are right-handed, it means we normally put it on the left hand, the upper border of the left arm. That is the non-dominant arm. For all hormonal contraceptives, as I said, their mechanism of action is that they inhibit ovulation, thicken cervical mucus, and they can thin off the endometrium. But the main mechanism of action remains inhibition of ovulation. Ovulation does not even occur. So for those of us that tend to be more churchious than go, and we say what God has put together, let no man put asunder. From what you have seen on this slide and what I have voiced out, it inhibits ovulation. That is to say, the egg is not made available. It didn't even escape from the ovaries. It mature and die inside it stayed there inside the ovary. So there are something like sperm meeting the egg to form zygote and morula and all the rest. I'm talking about implantation on the embryo. No, because it doesn't even happen. And that's the beauty of it. For those that emphasize moral consciousness, that there's no issue about that. This is opposite the mechanism of action of something like IUD. We'll come to that. The main side effect is irregular vaginal bleeding and others. So when you are asked the side effect of any hormonal drug are mainly two, just two: irregular vaginal bleeding and others. Then you say what are the components of irregular vaginal bleeding, which include heavy menstrual flow, otherwise called menorrhagia, no menses, otherwise called amenorrhea, intermenstrual bleed, spotting, and so on. These are grouped under irregular vaginal bleeding. Then others are based on the fact that it's a hormonal drug, and if it's a hormonal drug, it retains fluid. It retains fluid, and if it retains fluid, retention of fluid in the brain will give dizziness. It might give headache. Because it retains fluid, it may lead to raised blood pressure. Because it retains fluid, it might lead to weight gain and so on. However, listen careful now. I'm saying this with emphasis. See, when you talk about the side effect, it's not as if somebody has a list. You see, the side effects under counseling, the truth of the matter is that of all the people that have this method, only few will come back to complain. Most of them will start it, they done many years, they come back, say happily, say remove it, we remove after the other one. It's only few out of thousands or out of hundreds. Only few out of hundreds might come back and say and give one of these two things. One person might come and give one, the other person might give another. Just like that. And you should know that, and this is emphasis on all hormonal contraceptives. I'm not going to emphasize them again. Just like here, you can see mechanism of action of IUD. Okay, this one is IUD. So we'll talk about it. IUD is also, that's intrauterine device. Before now, we call it intrauterine contraceptive device. It became a stigmatization. And because of that stigmatization, we are not happy. We are now limiting it to intrauterine device. So not when you come, I want a transition contraceptive device. Every person will turn and look at you because you had contraception. So it's also a long-acting reversible contraceptive that lasts 10 to 12 years. Before now, following what I told you in history and camel and stone, that stone is inert. It doesn't have any chemical. So the first one that devised based on that stone was lippy sloop, which we don't use again because it's inert. It does the contraception. But the efficacy cannot be compared to copper T, where copper is added to an inert rod, flexible rod, becomes more efficacious with almost efficacy of 99.95%. It is placed on the uterine cavity, and the mechanism of action is that it's not as if there's an error here in terms of inhibits implantation. Not necessarily an error. What I'm saying, the other one inhibits ovulation. This one inhibits implantation, which means after fertilization. When there's need for now implantation of the embryo, it acts as barrier because it's a substance placed inside the womb. It's a kind of a space occupying lesion. It has already occupied space, blocking other things from also implanting. That's number one. Number two is that it's spasmicidal. That is to say, it can wipe off the sperm to make sure that it doesn't go to now fertilize the egg. It can even wipe off the egg that is there. You find out that it's also feticidal. That is to say, it can lead to death of the fetus. And that's why it's used it can be used as emergency contraception. When we go to the chapter that the part that talks about emergency contraception, you see me mentioning it there. So this is, in terms of mechanism of action, is almost the opposite of that of the hormonal method. So that the patients have choice, the clients have their choices to make, decide the one they want and be on it. That's the way we look at it. Now, the side effects are mainly four. You remember that when we're talking about hormonal contraceptives, we say the side effects are mainly two: irregular vaginal bleeding and others, and we have explained it. This one is mainly four, and therefore are heavy menstrual flow, infection, as seen in vaginal discharge, menorrhagia, heavy menstrual flow, infection as seen in vaginal discharge, pelvic pain, low abdominal pain, others as in expulsion, perforation, missing IUD. Now, those first three, heavy menstrual flow and vaginal discharge or infection and pelvic pain, are mainly, or even expulsion, are mainly because it's a foreign body. And you can imagine it yourself as you're sitting down there or as you are looking and they are listening. Something foreign, not even flesh, not even bone and flesh, not even part of human, is inserted into the uterus. It will be new to the womb. It will be new to the uterus. Uterus will struggle to push it out. You are not part of me. That struggle to push it out will lead to lower abdominal pain that comes and goes, which in medicine we call colicky abdominal pain that comes and goes. The uterus struggling to push it out. And over time, over 2 or 3 months, all these things will disappear because the uterus will learn to live with it, because it has not succeeded in pushing it out. It has failed in pushing it out. They live like teeth and tongue in the mouth, harmoniously, and nothing will happen. It's the same vein, because it's foreign body, that you find out that menses can now be heavier because the rate of contraction will increase, causing more of this. And because it's foreign body, the uterus or the womb is flushed every 1 second, pushing out. That's why the vagina is continuously wet, because there's always the way God made the uterus to wash, otherwise there have been infection everywhere. It washes it down and flow out from the vagina. Now, because there's a foreign body there, and if you know copper T, if you have ever seen it, is you see something like wire rope tied on a rope, on a stick, on a T stick. Because it's corrugated, it traps some of those infections, some of those things that are being washed out. Instead of washed out, it gets trapped there and multiply. As it multiply, infection ensues. So perforation is not common unless done by a quack, and missing IUD is also not common unless a quack does it. So we talk about injectable this time, and injectable is a hormonal drug. It's a hormonal contraceptive. So we're not going to go to mechanism of action and side effects. We have said it captured. So we look at it. There are two types: Depo-Provera, which is very popular, and then the Noristeras. Why Depo-Provera lasts 3 months, Noristeras last for Noristerat Elantet lasts for 2 months. It's given by deep intramuscular injection, and that is a kind of disadvantage. Deep intramuscular injection, because it's a depot. You need to deposit it there so that it will be disseminating small in micro fractions. But You and I know that there's a you can't compare something every 3 months or 2 months. Somebody comes with took injection. One day there might not be sterility, it becomes injection abscess. It's a problem. Another one is that the person has to be visiting the hospital regularly. It's also a problem. So we talk about oral contraceptives again, not visiting the mechanism of action and side effects. We have said that. The combined oral contraceptive, combined either estrogen and progesterone, or them are even just one case with it, like the mini pills. It's not popular in Africa because we are not regimented people. We are not regimented. Many of us can now vouch how many they take. And when you say it's a daily pill, it's not actually a daily pill. It's a time pill, time, in the sense that if you want to be on it, you must make up your mind that every morning you take it, or every afternoon you take it, or every evening you take it. Not today you take it in the morning, tomorrow you take it in the afternoon, next tomorrow you take it in the evening. It will fail because the quantum that is needed to be maintained in the serum, in the blood, will not be maintained at a particular level. By the time you take it in the morning today and the evening you take it, yeah, the effect don't they go now? It's more than 24 hours. So that is a very big disadvantage, which is not good with us. So it has higher failure rate compared to other long-acting reversible contraceptives that is just there. It's just there for 5 years, just emitting or releasing almost a very small quantity, 0.625 micrograms of progesterone every day. But it's constant, so it won't fail. So based on this, it can fail. Another important thing worth mentioning about oral contraceptive that is no longer popular as a contraceptive method, especially in developing countries, as I said. But it's very, very popular in many other things, what we call non-contraceptive benefits. And that's why myself as a gynecologist, a week hardly passed that I don't prescribe it twice. Not for contraception, but for the non-contraceptive benefits. It has given me some coins, very sharp, very useful, very effective, beneficial effect that patient will be very, very happy. Just like to treat polycystic ovarian syndrome, inhibiting conception, or harassing a young girl with her menstruation, especially the one that for correcting menstrual problem in a young lady. Polycystic ovarian syndrome, oral contraceptive is very, very useful, very effective. It can be used to control menses, regularize menses, or pimples in young girls. It's very beneficial in most of these things. So the next method is surgical. The next modern contraceptive method is surgical contraceptives, which will be bilateral tubal ligation or vasectomy. That is to say, cutting the vas difference in a man or tying the tubes, the fallopian tubes in the woman. Both of them are very, very effective. But tying the tubes is far more costly than tying and simpler. Tying the tubes is far more costly and more invasive than the very cheap method of vasectomy, tying the man's vas difference, which is very cheap, very simple. But the other way around now is the case because there are thinking that make it unpopular. So even the women say, instead you go tie my husband vas different, tie my woman. I don't want to play with say there's loss of turgidity of the penis, that is potency. It's no longer guaranteed, which is not true. But these are the things that are barriers to this surgical contraceptive. Also, because it's an operative measure, or because it's permanent and irreversible. It's not popular. Psychological issues of pain is there. These things are just thinkings of the mind. It's not as if there's any scientific basis or evidence based. No. But that's the situation, and then it's working against it as a method. I think the last but not the least among the modern contraceptive methods is the barrier method. We can talk about condom in female and male condom, female condom. Others are sponges, foam, and others. They are not actually popular because the failure rate is high, but people still use them because it's something you can use sharp to make sure there's no unwarranted pregnancy. Their mechanism of action, as we said, is barrier, and their side effect is mainly irritation due to the chemicals it's embedded with. So we are worried about these are the possibilities. Now, emergency contraception is the protection of pregnancy. Emergency contraception is protection of pregnancy done after unprotected sexual intercourse. Also, it's called postcoital secondary morning after pill. Indications include assault, contraceptive failure, and so on. So the methods could be any of the contraceptive, either IUD or pills in high doses. The higher, the better. So the mechanism of action, if it's any of those progesterone, as we said, it prevents ovulation. So for IUD, you can use IUD, that is coil, copper T, even when the person is pregnant for up to 7 days, you can insert it, and it can now prevent pregnancy or make sure pregnancy does not progress. Post-abortion contraception. Post-abortion contraception. Any contraceptive method can be secured for it. Any type can be used in the immediate post-op method for guaranteeing contraception that the person doesn't go and take it again. IUD, as we said, that is a coil, can be used in the first trimester to make sure the risk of expulsion. Then after an abortion, you can use it in the first trimester mainly. But in the second trimester abortion or even the third, there's risk, especially in the second, there's risk of expulsion. Yes, I said that copper IUD is actually used for an emergency contraception. It can be used even when the person is pregnant, confirmed pregnant for almost 5 weeks, that is to say 7 days post the ovulation day. You can use it to secure an abortion. Yes, that's what I said. IUD contraceptive indicated after septic abortion. You remember what we told you about infection? That if the person, that IUD on its own may cause infection. And that's why we don't use it for multiple sexual partners. People that have sexual partners from many places, they find out that the chances of the woman having infection with the IUD is high. So when abortion is already septic, infected abortion, after that abortion, you don't need to use IUD because problem. So in counseling, we discuss with them the various methods and then how to prevent them. Provision of family parental plans of contraception. We have counseling, That's a family. What are the services we render at the family planning clinic? One of them is counseling. Another service we render in the family planning clinic is contraceptive services. A third one is opportunistic screening. That is to say, you can screen for cancer, you can screen for STI, HIV, and so on. You can screen for pregnancy. So opportunistic screening can be done, and you can do any of them. Also, you have a research. It's another service we render there. That is where most of us have grown to be somebody. And also, the service we render there is manpower training and capacity building. As I'm talking to you now, I'm developing your capacity in family planning services, which will be great to the nation, if not today, tomorrow, depending on your own, how you choose to move. Good. Sorry, I have small network issue, but I think it's back. So, in counseling, you listen very well, because this is a critical area we take seriously doing an exam, because counseling is very important for those of us that will be on it tomorrow. There are two things we want you to learn in counseling. Counseling is about telling the patient or the client the direction she's going, all the information she needed to know about the method she wants to go in. Give her all the information she needed to know about the method she wants to. If it's IUD, give her everything you know about IUD. Correct information so that she can make what we call informed choice. And in giving that information, you should not be judgmental. That is to say, something like the woman now tells you that, yes, I have done 21 termination of pregnancy. You will say, up to 21? How can you say that? You have already embarrassed the client. You have embarrassed her to the level that she will be too shy and ashamed to give you other information in that line. She will withhold them. So we emphasize not being judgmental, very important in counseling. Or you see a girl that is 17 years old, or let's say even 22-year-old, or 20 or 19. I know why I'm choosing these figures now. Let's say 19. A young girl, you know the parents, or you don't know them. Only the non-verbal communication you will give her by sternly looking at her as if she has committed suicide, or if she has committed adult, or he has done something abominable. That will make her shrink into her shell and will not give you further information. She might even quietly walk up, do I pretend that this is going somewhere, and disappear from the scene. You have caused trouble in your counseling. So you should not be judgmental. Not to talk of saying, what you can do, Josephine? What you can do inside here? How can you ask that kind of question as a counselor? So you don't do all those things judgmental at all, never. Or you don't pay attention. The poor woman also is telling you something, you are busy receiving phone calls. You must be very, very attentive to whatever he's saying. You must listen to her quietly to get all the information you needed, explain everything, as we said, all the efficacy and everything, give all the information, get a feedback from her, ask her all her questions as need may be to make sure that everything she needed, she got me. Be a very good listener so that you encourages her to talk more. You ask questions that will lead her to talk more. And the non-verbal communication is very important in the sense that if you use the wrong one, the patient will shade back. But if you give correct one, as if the person talking, you're nodding your head forward, the person will be impressed and be giving you more information. So non-verbal communication in counseling is very, very important. So as we're rounding up in this first section, before we go to the second section, we would like a situation where we look at the applied method. Applied, all these things we have been talking, will be broken to naira and group in such a manner that it becomes appreciable, not just for us now, for them to ask to come for this training. It's not just because of modern contraception and what it takes. Yes, for you to learn it if you don't know it, but then more importantly, for you to appreciate the application, the usefulness. How does it help us in moving the nation forward? How does it help us in population strategies? How does it guide our population guidelines? How does it make our population guidelines so that every person into this ecosystem will coexist healthily and happily? That is the bottom line, and that is the meat of the matter. That is the meat of the matter. So we'll be talking about accessibility and then availability of family planning method. How accessible is it? How available is it? The answer is that almost all the family planning methods are available. Yes, it might not be a news to you. It might not be a news to you. But anytime I'm talking, I want you to place yourself in the shoes of those in Ekerebo local government, those in Bundu Waterside. Don't sit in your comfort, because you and I constitute less than 5% of the population of this country. People of our level, you cannot imagine you are small level, my very small level, you are very small level, but we belong to 5% of the top of the ladder. When you start talking about those high our politicians and their money and everything, those people constitute more than less than 1% of the population. But let's say for you and I that can maybe afford up to 2 meals a day, we constitute about 5% of the society. So the other 95% are living in squalor, just like in any other African country, just like any other developing country. The people, civil service group that can afford, not all civil, are you talking about level 5 and below, assuming that they're living on their salary? No. Talk about you and I and above. You and I are on the lower ladder, on the lower grade of that top ladder. 5%. So those 95%, they don't know what you're talking about, all these methods. They don't know that they're there. Many of them don't know. But for our aggressive quality evangelization, master strategies we are using, they've revolutionized people, the uptake of family planning methods. If not for that, most of them don't even know that there's something like the one they put on the inner arm of the hand. They don't know. If they know there's something like that, they don't know that it's at their doorstep. It's at the doorstep of almost every person. They don't know. And that's what we're talking about, accessibility. And that's why if you look at this, I highlighted it on red to show that that's where the issue is, not availability. It's accessibility. Now, even if they know those in Bundu Waterside, Ekerebo local government area, those in my village, even if they know that something like that exists, there are other barriers hindering them from accessing it. Other barriers making accessibility an issue. And those barriers are, before now, cost was a very big issue. Cost was a very big barrier. In fact, one of the biggest barriers, but that barrier has been broken. That barrier of availability because of cost, or accessibility because of cost. Accessibility because of cost, where it's available, but cost is hindering access has been broken. It has been broken because in the introduction, if you remember, I said in most developing countries, let me now talk about Nigeria, I know, where I'm, so to say, an authority in that area, that is free. And that in that introduction in history of contraception, I said that the last bullet said that you cannot discuss public planning in Nigeria without giving mighty appreciation to the non-governmental organizations, which have been working hand in hand with governmental agencies in terms of coordination to make sure it's uniform, making it available. Those non-governmental organizations are super notch. They have trained people to make sure training is not a problem. They have brought it free in partnership with the super non-governmental organizations abroad, like Clinton Access, Blender May Gates, and so on, Ford Foundation. Before now, I learned Trump had brought it back again. United States International Agency for Developing Countries. Nothing is free in this world, which you know. For something to be free, somebody has paid for it. So these contraceptive services are free with us because the super agents abroad has paid for it. Don't worry, we'll capture it more when we talk. That's the essence of social marketing. We will come to that. When we come there, we emphasize. So the awareness and knowledge is, say, to some extent, a barrier. And we are looking into it. Poverty of education, ignorance. They say ignorance is a disease, and it's a disease through. Culture. You, just like I keep saying, you may not believe that some women, before they can even come to family planning clinic, they will take permission from their husband. Male dominance, culture, and male dominance. In some parts of this country, before a woman set out to go to anywhere, especially maybe clinic, more so family planning clinic, the husband must give permission. Otherwise, when you come back, you will be sacked from the house. In some areas, yes. And even because of COVID, they might not even have money to take transport to go to where they are going. So it's an issue. The one that is of emphasis is religion. Religion. You see, the level you have gotten in life, no person should bamboozle you. Unless you want to be bamboozled. No person should bamboozle you. Or unless your academics, your training is a waste. You see, at times I enter something in the house, so maybe one small argument about religion in the house, house things, husband and wife matter. I remember one day the argument got to the level I said that I worship with my eyes open. My wife says, stop saying that. Oh, is to enter church. Do your thing and go. I say, lie. It's not like that. So if I enter now and somebody will say, okay, keep your head down, put your leg up, I will do it. See, I'm not saying you might, if you come close, you know that you might not be more religious than I am. Lie. Maybe you might not be holier than I am. Secondly, but things must be put in proper perspectives. More so in academics. and also application of academics to help you tomorrow. You must look into all this. And that reminds me this range. I gave you a quotation in the history of contraception. And I said that God commanded us, go into the world, multiply and fill the earth as a first phrase, because our God is wise. Because our God is wise, you find out that also he commanded us to conquer the earth and take dominion as the second phrase. Now we put religion here as a barrier. Most of our preachers, our pastors, our clergies will not say things the way our wise God has put it, the way our omnipotent, omniscience God has put it. They will just go, either for reason based on to them, I don't know, either for just to not be just being interested in the tithes that we follow or whatever, I don't know. But how can you, God gave you a sentence to make to people you are shepherding. Go, simple sentence, go into the world, multiply and feed the earth. Conquer the earth and take dominion. Various versions of the Bible have various ways of saying it, but this is one of the oldest, and that's the one I'm using. I'll give you an example to buttress what I'm saying. That we are not interested in shrinking the population. No. You get it wrong. No, that's not the issue. The issue is marrying the population and the availability of things to sustain that population to make sure there's a balance. There should be equilibrium so that every person will be happy, live happily, and healthy. That is the issue I keep saying from day one. And that is the issue about the whole topic we're talking in the next, in this topic, in this discussion of 2 hours. So if you use China, let's use China. China is about, it's the most populated country in the whole world, in what I know. I don't know whether there's any doubt to that. And I know that India is second to that China. That is the information I have. If it has changed, I don't know. But I think that's it. Sorry. Mute your mic, mute your phone, please. I would not want interruption so that others can listen well. Now, if that is the case, listen well and follow me in the reasoning and the judgment. I said China is about the most populous country in the world, and the fact that the highest populous country in the whole world. And I said, if that is the case, China is also about the biggest superpower in the world. Leave America. You decide where you are sitting now, you start arguing within your mind. No problem. That arguing in your mind is part of what I want for us to brainstorm, use our mind, think loud, and make something out of our discussion this year. China is the most populous. It's about the superpower, economic superpower of the world. When it comes to economy in particular, economic superpower of the world. And I, as an expert in population dynamics, I mark China good. And I wish China multiplying their population every day. It doesn't matter because they fit into the gospel we're preaching. that the issue is that there should be equilibrium in population dynamics. There should be stability. There should be health. There should be happiness. Mother should not be punished because he's bearing children. Children that the means of sustainability is poor. Children that cannot be well trained. Children that cannot be well fed. Mother that cannot eat well because of the number of children that are there. Mother that cannot take care of herself because of issues surrounding means of living healthy and living happy. That is our quarrel. Therefore, we are happy with every country that is maintaining this equilibrium, maintaining this balance, and making sure that every person is happy, especially mother and child. Because a happy country, a wealthy country, is a country where the mother and the child is healthy. Because when they're healthy, they grow well and become the pride of the nation and the family. That is our preaching. And China is meeting that level. China, with that huge population, is feeding you and I. In most developing countries, they are giving us loans. They are helping us grow our economy, despite their population that is the highest in the whole world. And that's what, they are the people doing what God has commanded us to do. They have come into the world, multiplying as God has commanded us, to feed the earth, which is good. They have conquered the earth and they have taken dominion. What else do you want? Here, in most African countries, in fact, in all developing countries, their pastors will tell them just go into the world, multiply and feed the earth. There's no input on how these people are gingering on them. Few pastors do. I do listen to them, few of them. Very sound, nice pastors that will tell you that you have to be careful about this and that. You have to work hard. They even empower some of their members to make sure they live above God. This is what we do, and that is the right thing, and that is good. So religion still remains a very big problem, where you see them many, you still encourage them, just open your legs before feed the air. We have to look at it twice. We also say that age is a limitation. It's a barrier to accessing contraception. If you remember what I said in counseling, if I remember what I said in the counseling method, in the counseling section, I said that some of these girls, younger people, say 18, 19, 20, all these below 25, when they come, people will be looking at them with strange eyes, with unwelcome eyes, with non-verbal cues that suggest, what are you looking for here? You are never inside, you're not even married. You started coming for contraceptive service. So you prepare her to become a single mother with many children around, or to go and take in, that is even the worst, and involve in unsafe abortion and die from there. Which one is it? For you to support her to involve in unsafe, sex is there as a word there. More than 1 million sexual intercourse is recorded every blessed day. More than 1 million every blessed day. So what is the issue? It must be happening. The important thing is what if it happens, what next? I'm now asking you a question. Is it better for her to die not do contraception, take in, go do a self-abortion and die from it. It's to your conscience. Just as you are listening to me, the adding up. Tomorrow you won't know where you will find yourself as a policymaker. These thoughts should be shaping your mind going forward. You will choose between killing the girl and protecting her. It's an option for you. Another barrier, important barrier, is terrain and logistics. I've mentioned one area, especially those that live in islands, in riverine areas. If they don't have family planning clinic there, they need to come out to the mainland where they will access it. That might be a problem. Also, logistics of money, even when money is there, some places are not accessible by road. Some places are not accessible by road. It's also an issue. So it's a logistic problem. So you find out that you must do all these things to now overcome all those logistics. How do we overcome them? We are overcoming them gradually. Like now, especially in rich states like River State, wealthy states like River State, there's hardly any new training. We don't have family planning training. There's hardly any. So based on that, but we're talking about some other places and also government policies. Are they looking into all this to make sure everywhere is covered? Not to make noise. We have launched every 1,000 family planning clinic or clinic everywhere. On paper, these are issues. You don't know whether you'll be a commissioner of health tomorrow. Your conscience should break you. So you look at all these things, you start worrying. The attitude of the providers is becoming a worry. And that's why I emphasized it from the beginning. Nonchalant attitude, judgmental attitude, laissez-faire attitude. If you come to where I work, University of Port Harcourt Teaching House, we have a fantastic family planning clinic with well-trained providers who, when you look at them from a distance, in fact, you don't even need to talk to them to learn counsel. Just watching them counsel a woman, you can sit up and go. For any of you that might have chance or might close to UPTH, I need there, especially on a Tuesday, walk into that place around 10, 11 and listen to those veterans counsel these patients. You see what I mean? You see all this is I'm mentioning, typify in practice. And you will retain it that any day you are asked, you vomit it like that. And you won't have problem. And many other ones, as we said, just like government policies are there. So, in availability and accessibility, I told you that it will be illustrated in one of the subtopics of this first section of this discussion, which is social marketing. Social marketing. If you look there, you see I wrote social marketing in capital of contraceptive methods. I did it that way because social marketing is not limited to contraceptive services. So I don't get it wrong. It's a method that has been devised to make sure that every person that needed a particular important service receives it at affordable cost. At affordable cost. At affordable cost. I give you an example. We said that contraceptive services is free, and I remain with that. I give you an example. Buttressing what I just said. A woman might walk into University of Port Harcourt Teaching Hospital Family Planning Clinic, and matron, after all the counseling and everything, to now insert, he say, "Madam, you will give us," and I'm quoting, I'm not misquoting. "You give us 1,000, but I know that now it's 1,500." The woman will now say, most of them will bring, but I won't blame that extreme poverty, which is a disease, or being mischievous. They will say, but our land is free. Good. I am telling you now, as you are listening to me, that to insert implant in America today is in the neighborhood of, I don't know whether they're still bringing it down, but as of, I'm quoting the day I have this information, it's about a year and a half. A year and a half to 2 years. We are on super training, what we call training of the trainers at Abuja to come and train Rivers, 2 of us. And I remember along the line, just not necessarily out of the discussion, but just mentioning for mentioning sake, the traders said that to insert this implant in America today, that is as of that day, as of that 2 years ago, about 2 years ago, will cost in the neighborhood of almost 200,000 naira when you convert the dollar. Now, if it's 2 years ago and the dollar conversion today, we should be talking about maybe about 300,000. If the situation has changed to the right or to the left, I don't know. I've created a scenario to you. Now, if you use that 300,000 for our discussion this time, and somebody, because federal government instructed that since this thing is brought free, no money should be taken, it shouldn't be given at the charge. It shouldn't be given with the charge. All you ask the patient is to give you the money of logistics to come from the matron and teaching hospital. We go to central store of River State and pick the consignment. He will pay transport to that place. What was given free was the consignment, either implant, non-implant, all those kinds of things. The spirit or betidine, the methylated spirit or betidine iodine solution, or cotton wool, or syringe to insert any of them was not given. That 1,000 naira, they say bring. If they ask you to go and bring those things, just bring them. Get me cotton wool, get me syringe, get me betadine, let me insert this thing for you. By the time you bring all those things, you must have paid like 10,000 naira where you buy it and come. They have bought it in bulk, and that's why federal government has worked out the mathematics and instructed that not more than as of the time that rule was made. And now they're taking 1,500. I believe that the rule has changed from 1,500 from 1,000 to 1,500. I was in the seminar that decided for that 1,500 before we started the federal government to approve. When we costed everything, that's what it would take to go and bring it, naira for naira, no kobo gain. And somebody will tell you, I thought it's free. So they are giving you something of about 300,000 naira free, put. There you are paying for cotton wool, spirit, transport to go and bring it. You can go to central store, bring it for them, they will put for you still. So we should be reasonable, and I'm telling you the gospel truth so that you know I'm better informed. Should you challenge meet any challenges in your practice or in your doing things or carrying out a function? And in policy making tomorrow, so that you know that logistics are also taken care of. Otherwise, they will bring all these things. That is what is a policy. They bring all these things, keep it, nowhere to put it. Every person, hands up, problem everywhere. Things must be made to work at a very affordable price. That is no money. So that is social marketing. What we said for social good, the essence primarily is for social good, to make sure that every person is carried along, both they have and they have not. And that is the level of awareness, so that when these things are done, people will be aware and behavioral change of not accepting, uptaking contraceptive service will be a near death. And every person that needed it will have it. And that dies the matter of unmet needs. It will be there. And this social marketing for social good is just the opposite of the commercial marketing. The primary aim is to good. The primary aim is financial gain, just like people selling in the market. They bought the bag of price 5,000, they must sell it around 6,000 so that they can buy it more. So this one is social good and it's used in many places, including health. It's even used in engineering. It has been there since the year 1951 and it's still not good. So the concept of pricing is different, distribution is different based on what I have said. The illustrations I've given you are captured in all these components and concepts I have seen. The pricing, you see the difference between commercial pricing and social pricing. You see distribution, Metron going to pick it with little or no money. The patient pays one kobo. When they add everything they're going to do, it comes to about 1,000. And they're just retailing it and then branding and corporate imaging so that there wouldn't be any adulteration. Research will be going in those governmental organizations' approach and it keeps moving. Strategy and operational method of components of it and ethics are also maintained as a component. So the branding, direct marketing is for commercial marketing and loyalty. This also mainly trying to distinguish between social, all these things are corporative. When you look at it, you know, what does it take in commercial marketing? What do you think should be in social marketing? For example, advertising in let me say advertising conduct in television under commercial pricing. When I say it is strong and the advantage is 3 for 5 naira or 3, let's be more precise, is advertising in commercial marketing. Commercial marketing is very raw, strong, and hardly fails. You see, this advert now is telling you something so that no matter the price they place it on, you can buy it. But when you go to social marketing, it will tell you that this thing is very cheap or even free. But you find that it protect you from it has dual protection. One of them is that you won't be pregnant. The other one is that you won't have infection. For example, I'm giving you. So the same way for other contents and components, that's the way you go. You reason it in commercial marketing and reason it how will social marketing look at it in broadcasting. You look at all these things and then you know the take home. In all, out of home and behavioral attitude is important. That when you look at all these things and you uptake them based on all these components that I've said, it makes sense that you should key into them and make good use of them, take good use of the opportunity, and make sure you don't make a mess of yourself or the person's self for something that has been given to you almost free. In fact, free. So these are the way we are looking as we are coming to almost getting to the end of the first phase. The second phase is about 30 minutes or so, and that will bring us to about when are we closing, sir? We are closing by 8:30, Abi. Let's see.
We can close by 8 or 8:30 or 9. We can close by 8:30 or 9, sir.
The way it's going, 8:30, but this is up to 9, Abi.
Yes, I can extend to 9. 9.
It's long.
Yeah.
I think we'll close by 9. Just look at 9. No, we didn't start on time. We are waiting for you people. It's not my fault. So, but let's say, but take it seriously from now on. Since we enter the applied method, that's the time you have to be careful. Take everything. If you are listening very well, you notice that what we are talking now, if you don't listen, as you go to the slide, it won't make much sense to you. It's only when you listen that the slide cannot be helping you to remember and apply when you are asked questions in exam. Because most of our questions are based on the application, though. I'm telling you now so that you know. Because that's why the trading is there, not because of the basic part. All of them are important. Anyone can be asked. That's the truth. So the application and impact, as we were talking. Policy making. For example, strategies for improving family planning services. What are the strategies? We have drawn them, making sure that these things are available, and that is the strategy. And non-governmental organizations have helped us a lot to make sure that the strategy of availability is there. And they're also helping us in accessibility. That is the truth. They bear most of the weight, supported by the federal government of Nigeria. And federal government of Nigeria, saying the truth from my observation as an insider in this business, give them all the logistics they needed to succeed. They bring it in. Federal government did not pay for it. They bring it in through these super non-governmental organizations I said abroad, like USAID, Melinda Gates, Clinton Health, all these people bring it in. Federal government now give them all the logistics of training, logistics like cars, things to move around, all those kinds of things. So federal government is playing its parts. They are playing their own major role too. So it brings to that attitudinal change we are talking about, the impact of application of social marketing on accessibility and availability. That once is there, the attitudinal change in the policymakers in terms of building health centers that incorporates family planning clinics, training manpower and retraining manpower, making sure that all the policies are there, that the workers are trained, making sure that the trained people are doing what they should do, the providers are doing the normal counseling and application of the devices chosen. These are the kind of policies that will make it work and make sure that everything is, the strategies are right to make sure things are done. If not for this kind of training, this kind of strategies, people like us cannot be talking to you. When I joined teaching hospital as a young consultant, incidentally, call it 14, 15 years ago. And we felt that was when the impact of long-acting reversible contraception was coming in, because that's where the trend is going. And many of us were trained by these non-governmental organizations. Many of us. In fact, virtually most, if not almost all the people that are practicing long-acting reversible contraception in Rivers State and Bayelsa to some extent are trained by ourselves, that we are trained those days. We are the first state that we are trained. So after those training, which is training of trainer, we have trained many training of the trainers, people which have been training. I'm not even involved in now direct training of trainers. So to tell you the impact of such policy, such strategy, and the fruits and the impact it has yielded in turning around our contraceptive services, that the uptake is shifting from, when I started, it was about 7.2%. From there, it has been galloping. Today, it's almost 20. So we're moving. And that is the impact of good strategies based on what I'm saying, non-governmental organization in conjunction with the federal government of Nigeria and super non-governmental approach to make sure things work. So based on these things, the evidence we have been getting that things are improving and things, the uptake is increasing. Based on that, the training is also increasing. Because it's an evidence that you have trained people who have trained people and who are training people, and the multiplier effect is working. That's an evidence based that you should keep moving in that direction to get more results and then get things well done. The last year is community-based social market, in the sense that we emphasize so much on this, what they call it again. We emphasize much on young people being disadvantaged in accessing contraception because of the barrier of their age. So some of them have formed community-based social market. A good example I know is the so-called youth champions. In that place, there are facilities for something like games and other things that are entertaining, even for teleto, all those things. They go there, they say it's for young people. But the main aim behind it is that there's a small clinic for family planning for those who wish to. For those who wish to. So inside there is all young people now. So there's no barrier, there's no limitation. No person will look at you one kind, as I said before, with one kind eye, corner eye. Why are you here? So you will happily go and obtain one and sort yourself if you so desire, because it's a personal desire, as I said. No person is pushing anybody. So policy formulation and implementation in this concept will now mean that population of Nigeria now is stagnant. And it will be worse by the year as postulated, year 2050. It's actually guessed that by year 2050, I say guessed, the population of this country might be the third highest in the whole world. Might be, which means it's just a postulation. Policy changes tomorrow might shift it to number 20. So we watch and see, but we work with postulation so that we can plan well. So if that is the case, we need to wake up and be very, and we are watching it. We are watching it in our population dynamics studies and implementation. Just like you see here, it's about 17. Remember I told you when I joined some 15 years ago or so, it's about 7%. Today it's about 20. It's about 19 point something. I'm sure of that one, not of the 20. So you now look at all these things and see what is the policy. The policy today that we go to national store, as I said, pick and bring to the small clinics around, including our hospital, and dispense from there. So way forward is that government should. Yes, government is trying its bit from my observation. I didn't give them the credit total from the one which you have noticed. The most important people I give credit to non-governmental organization, and that is the truth about family planning in Nigeria today. The government, I said, has done its own bit by giving the logistics from my observation to make sure they succeed, because it's in the interest of the whole Nigeria. And the same things are applied in virtually all developing countries. I'm using Nigeria as a case study because that's where I am. But I can tell you authoritatively, from studies gotten from other countries, I know it's virtually the same thing. Their government is giving logistics to NGOs in the countries who are relating with super NGOs abroad to make sure that we get to where we are going for the safety of every person. And that is where we are looking at. So we conclude this portion and go to the next portion that will take us just 30 minutes or less by saying that attitudinal change in positive health-seeking behavior occurs when knowledge and use of family planning tools has taken place. So you start doing things well and you start reasoning better and then things happen. You have no option than to do that so that things will work. And there's no person, no, okay, I don't know, but generally speaking, I know there's no person you put in sugar into his mouth that will spit it out or glucose. You will lick it without happiness. So those that don't know, for us that know, including you that know, most of what I said, more than 95% of the population don't know. When they know, it's expected that they should have change, health-seeking behavior, good health-seeking behavior, to make sure that utilizing these devices or family planning methods to live healthier, in the sense that even if they wanted 10 children, they might need to space it in a way that their physiology will come back before they take it for another one. That's the point we're making. Not today, tomorrow you take another, next tomorrow you take another, next tomorrow you take another. Meanwhile, you don't have that enablement to maintain your body physiology in terms of eating well. The protein, the poor labor comes back from work every night and lands on you. Pregnancy don't check. So we have to, once you are cued in, you cue in others. Family planning is the ultimate key to a quality life for all, and must key into it. I hope as I'm keying into the next one, I hope there's no question, or is there any question?
So would you like to talk about the question you asked me to remind you about?
Is the question on the Bible, isn't it?
So you're muted. Okay, yeah.
Yes,
about
yes.
the commission to reproduce and replenish the earth in Genesis.
I remember that I discussed it. That's
Okay,
the one I'm talking about, two things, and I discussed it, the two phases of going to the woman plan, and then the other one of I used China. That's the one when I was talking about China. All right, let me
right, thank
go
you.
to the next slide and conclude in the next 20 minutes.
My hand is up. I raised my hand. My hand is up. I have a question.
No, just give me 2 minutes. Just give me a minute or two. Yeah. Who is raising his hand?
Good evening, sir.
Yeah.
My hand
Good
evening, sir.
Yeah. Good evening.
Thank you very much, sir, for the lecture. Can you hear me, sir?
Yes, I'm hearing you loud.
Okay, thank you, sir. So my question, I have a concern with family planning methods. Okay, as public health professionals, we are advocates of gender equality and equity. But looking at the available options of family planning methods, we see that most of the burden is majorly on the women.
Thank you.
I would like to know what effort is in place, or how can we incorporate gender equity and equality in family planning, so that both genders share the weight equally and not just the women. Thank you, sir.
Thank you very, very, very much. This is a very sensitive question that keeps recurring, but we have the answer. It's a very important question, gender equality in family. I hope you are hearing me.
Okay, sir. Can hear you, sir. Loud and
Yes.
clear.
Yes, sir.
Good. It has been a problem and continue to be a problem because there's gender inequality, gross. In fact, if I say it's even lopsided, I think it's a better word. If you say inequality, it means that the percentage is here, percentage is not there. In fact, it's lopsided. It's lopsided just to the women, or rather, is skewed. For us that use scientific languages, is skewed towards the women. And the reason is simple. If you look at all the methods of family planning, almost all of them are used by women. It's lopsided, skewed, badly skewed. The question is, what can we do? And the answer is that women are the cause. The answer is that women are the cause. Or women are also the good, that's the correct language. Women are also the problem. I said it with very serious contentment. We have, if you look at services of the family planning clinic, one of them is research. It's from that research that I'm reason to where I am today, and many other people in that and in other universities and everywhere in the world. We do a lot of research there. The available methods for men are few. And the other ones that are in the offing are still on the scientific trial, like gospel and all the rest. That only one that is very effective, that I praised, if you were listening to me from day one, I praised this so much, vasectomy. And in my talk, I said that it's cheap, it's safe, it's very easy to do, to obtain, to carry out. It's a procedure of few minutes, comparatively to the expensive, risky, and
It's nice.
other method of the woman, which is BTL. We have done research. Listen, can you listen now? We have done several research. One of the last research, I was physically involved. Most of the research I do now are like the one I do with you people, the one I do with other people. But this particular one, I did it out of self-interest. I asked myself a question. This question has been recurring, even when we go for Abuja training and all the rest. Can't we find an evidence that can be published, proof to the women in advocacy that we do every time? At times I talk to 2,000 people in a gathering, that I can now use evidence to talk to them to convince people towards vasectomy. And I carried that in research. And in the publication I gave, if you Google, you will see it under my name. Revisiting vasectomy. Where do the women, revisiting male contraception, in bracket vasectomy, where do the women stand? That is what you will Google. You see what I wrote there. To the shock, in fact, the trend is even getting worse. To summarize that publication, women said, "Don't touch my husband's penis." The idea is that even among the very trend one, this one, it was grouping classes of people with tertiary education, and so on, even health workers. Almost all of them said, condemned, did not accept their husband doing vasectomy for a simple reasoning that it will affect the potency of the penis. I'm telling you about a recent study. So you can't sit there and be talking inequality. I understand. You people are the cause. I hope you understood what I've said now, so that we can move on. Hello. Who is there? I'm not
We are
hearing
here.
anybody.
Yes, sir. Yes, sir. Yes, sir.
You have-
We
we
are
are
hearing you, sir. Yes, sir. You're right, sir.
I have a question. My hand has been up. Can I go ahead?
You mean that
Please, sir, I'm not.
you
Please,
are
stolen on behalf of mine, sir.
women
Sir,
are
I'm not
no
clear with your
problem, sir.
explanation.
You're right, sir.
So one more question. So
One more
to go to the
question,
next
sir.
one,
Sir.
they ask the final question. One more question.
Sir, can I go ahead?
The
My hand has
explanation
been
is not
up.
clear, sir.
Go ahead. The person in the hand is Beauty Maswell Tobin.
Good evening, sir.
Yeah.
Thank you
evening.
very much for the. Thank you so much for the lecture. Yes, I have an observation and 3 questions. For the observation, I was thinking that since it's an online class, I do not know if everybody have the same level of exposure when it comes to the family planning methods. Maybe by each, as you talk about each one, you would have maybe shown us a picture of what it looks like so that they can have an idea of what it is. And then for the questions, I'm asking this because our exams are supposed to be in multiple choice questions. You did say that all the side effects of hormonal contraceptives are the same, but in one of the slides, the one for injectable, you said something about weight loss, whereas in the previous slide, you have said something about weight gain responsible for the blood pressure.
Thank you for that observation. Don't worry. That's another one. I will answer it. I will answer it.
Okay, then secondly, when you were talking about the barriers, you mentioned age, and you told us not to be judgmental.
Yes.
In fact, you even made a phrase of where we belong. Do we want to kill the girl or we want to protect her from dying? I want to ask now, as an expert in this field, what form of contraception will you advise for a sexually active 17-year-old? And then lastly, I want to know what will be your take, because I'm also thinking from the preventive perspective. What will be your take in the introduction of sex education in secondary school? Thank you, and over.
Okay. Now, let me start from the first one. Anyone I forget, you remind me. The answer to the weight loss and the weight gain. Know it today that if it's MCQ and it says hormonal contraceptive can give weight gain, the answer is yes. Another question says hormonal contraception can lead to weight loss. The answer is also yes. I believe that has answered your question, which means if I don't put it on the slide, it means that both of them should be there. Both weight gain, possible weight gain, weight loss is there. I have seen with my eyes once. And once, on one occasion. So some of these side effects are very, very rare. That's why I say, if it's specific question in MCQ, can hormonal contraception give weight loss? The answer is yes, capital yes. And if can it give weight loss? Also, the answer is capital yes. Weight loss and weight gain. So that answers that question. Number 2, for what will be my advice in a 17-year-old girl about contraceptive method? I so-called the opportunity gives me an opportunity to tell you that there's no ideal contraceptive method. That's one. Two, there's no room for a counselor to advise somebody on the one she should take. And that's why we didn't say advice and we say counseling. Counseling is a two-way affair. Advice is one way. Take this. But in counseling, these are the options. These are the side effects. This is how it was. This is you choose. You may guide the person to choose, but you wouldn't choose for the person. What do I mean by guiding? You have told the person, for example, that hormonal contraceptive can raise blood pressure to the roof. May raise, it might not raise. In many of them, it doesn't. It's just few that might react is what we're talking about. In that few, let's assume that a person belongs to that few of raised blood pressure. It's already, his blood pressure, normally her blood pressure is normally about, let's use something that we can understand, 180 over 120 or 120 over, say 170 over 110, the first time you are seeing her. That is not a person that will give hormonal contraceptive because he stands the risk of getting it worse. You will not say, this one you are looking at, I want you to look at it a second time. I have told you this about blood pressure, this about. Do you not think that this one is good for you? So you will say, okay, it's true. I forgot that's the one you said. It's not good for me. That is guided. You won't tell her, don't choose it or choose it. So answering your question, there's no advice. You can't say anyone is okay for her. IUD, he has already sexually active. Sexual activity means at least one sexual intercourse in a year. That is the meaning of being sexually active. At least once in a year. So if he has tested it, so to say, or if he has done it, and then you mustn't not choose particular one for her. He can, he can put IUD. You tell her the problems of IUD, that since you have not started having children, don't you think infection might happen and now affect your womb? She herself will tell you, no, it's true. I don't want infection to touch my womb. You won't say don't take it because infection will touch your womb. So you learn how to cancel. When I say you learn, I don't mean you that ask question. I mean as I'm talking to all of you. Is there another one left? I forgot to know. I think there's a third one.
Yes, sir. In a situation where this girl now it does not have a prior knowledge about it, that's what I'm asking as an expert.
That's what I'm telling you now, sister. Sister, we have said that we are canceling. Wait, we said that the essence of canceling. If you maybe you joined us late, you didn't start from here. I emphasize that the essence of canceling is for you to let the person know everything about that method you want to choose. That is the first thing. That is the first, even when we mark medical students, that's the benchmark. If it's something over 10 in that OSCE, 8 marks goes to the information you give that client on that method. So she will have all the information she needed in order to make informed choice. I made a statement like this.
Okay.
Okay,
thank you, sir. Yes, sir. Lastly is your take on sexual education in secondary school.
That's good. I think that's one of the most beautiful questions you asked. Plus the other one you reminded. In fact, all your questions are beautiful. Okay, you say your name is okay, good. So that one is part of, I think it might either be captured in the next one, this one we're going to now, or I don't know whether it is, anything about lecture does not necessarily mean that, I don't know whether this thing does not necessarily mean that you bullet it. You might forget some points along the line, you get what I mean? But as you bullet it, you might get what you want. Maybe in terms of talking, I forgot. In terms of, don't worry, I'm doing something. In terms of talking, I forgot capturing that sex education as one. You notice that almost all the bullet later I will talk. What I'm saying. So there was a person mentioned abstinence. I don't know at all, or what to do to make sure part of it they don't get pregnant. Haven't said this. You find out that after talking, they do what they want, so to say. Is the little. Sorry, I have some more distraction. I'll sort it out. The thing is giving me. Well, just wait. Why is this thing behaving like this? Deepin. Hello. Hello. Hello.
Hello.
Hello. I don't
Good evening.
know, but the thing is knocking off
Well,
my.
with you, sir.
Okay, let me. What I will do. Let me do stop sharing and reshare again. But the thing, I don't know why it's not. Are you seeing anything?
We are not
No.
saying anything, but we can hear you clearly.
That's a slide. Okay, let me reshare it again. I wonder why the thing went off. Please just give me in the next 15 minutes we're done, please. Let me just put it back and see. Good. So just give me 15 minutes, okay? All right. You are seeing it now?
Yes, sir.
Okay, so let's shoot. In the next 10-15 minutes, we're done. Now, the second phase of this is to look at just three topics: traditional contraceptive methods and practices, then sex selection methods, and national population policy. This national population policy would have been the first thing to discuss. But I saw it as setting the mass against the council. I said, okay, no. Let's, after we have gotten ideas, so that when we now mention it, we now appreciate what we're saying. Because if we start it for the first time, that's the way I thought it would be wrong. you are senior people. If you feel otherwise, rearrange it. It doesn't matter. That's why you see that the questions you are asking and the suggestion you are making are even at par with all the discussion I'm making. So we're talking to each other, and that's what you should be at your level. I learn from you, you learn from me. So traditional methods. The objective is just like I said, to mention all the things in a very simple matter. Once you're able to now tell us what are the traditional contraceptive methods, what are the methods of sex selection, and what is the population policy trust of this country, you are good and done. And that is our distance. So traditional contraception is age long. It didn't start today. It started before we started modifying it and now came to the so-called modern contraceptive methods. This has not pushed it to the background. Well, it has pushed it to the background, but it has not eliminated it. It has not eliminated traditional methods. They are still there. They are still there. When we go through it, you see that you might be practicing one or two of them. Maybe I might be practicing one or two of them, not knowing. But they are there. And if you are not practicing, you know that you know, telling yourself too that some people in your village or whatever, or lower class of people around you might be indulging in one or two of them, and giving them some benefits, but not as if it's maximal benefit or comparative to modern contraceptives, which is scientifically based and proven. So sex selection will also depend on individual preferences. Just as a gynecologist I am, obstetrician gynecologist, some women will have four children, maybe all girls, and be seeking for one male. Some might have 4 male and be seeking for 1 girl. It depends on preferences. To my shock, some of them will be fighting hell bent on equality of the sex. They have gotten 2 boys and 1 girl and fighting that the 4th one must be girl, so that it becomes 2 girls, 2 boys. These are preferences. And these are issues of human being, which we are not blaming any person because we are insatiable. And it continues like that. Our foreign policies is dependent to a large extent on our national policy. So all the things is pari passu in the sense that the national policy drives family planning help in achieving national policy. So it's hand-in-hand business. A well-formulated family planning interventions guarantees the health of the mother, the baby, and the nation. And this is key, and we should know that. Now, traditional contraceptive methods and natural contraceptive methods, it came before the advent of contraceptives, as I said, and still in practice, as we have said. The efficacy depends on individual use and under the woman's control. And the various methods, which is the one you must know, the essence of this traditional method, the other things we say they are preambles. The main thing is that the various methods are herbs. This herb is very, very popular. I saw one, I think almost 2 or 3 weeks ago, I saw one based on herb. Saw it live inside the vagina. And I asked the woman, what is this leaf doing? After good interrogation, I was able to establish that it's there because he used it as a contraceptive method, but he had not remembered to remove it. So the leaf was still inside there. Now, coitus interruptus, which many of us, as we're listening, many of us don't pretend. Let nobody pretend. Many of us are using it. Abstinence also, some of us practices it, especially after having children. Some men, we say they're not even doing it again. It becomes a court for judgment between me and the husband and the woman, who will drag the husband to me to explain why it's just because he's doing it outside. That's why one will keep saying that the absence he doesn't want to have pregnancy. The woman has refused to use contraception. So you see that these are methods that are also there. The calendar method has been an old method that is there. It's traditional. If you look at how it was these days and how modified it has been, you start wondering, why has it not been moved into modern contraceptive method? But the answer is simple. The answer is that not. You see, one thing about science is that it's something that can be replicated by virtually every person that have knowledge in that direction. So you find out that this thing is not dependent. The scientific basis is not. I'm not saying that it has scientific basis, but then it's not that sharp. I give you an example. You find out that for it to work for you, you must have a regular menstrual cycle. That's a cyclical method. It might, if for example your menses is every 23 days, every 23 days it must come. If it's every 31 days, every 31 days it must come. But this one that will be regular. This month it come 23, after 23 days it came. Next month you waited, it got to 23 days, it didn't come until after 30 days. It will fail. Because it's dependent on that ovulation also in terms of the rhythm that is we are watching. We dependent on the ovulation method, which we know, you and I know that the last 14 days is constant. For example, if my cycle is 30 days, it means I'm expecting my ovulation every 16 day of the cycle. And if my cycle is, let's say, 26 days, you remove 14, it means every 12 day of the menses. Every 20 days. So please, madam, mute your phone, please, or your device. So that is the thing. If that is the case, that's the way you must go. So if that is the case, see that it's not something you can predict very well. You can predict science that one plus one must give you 2. That is science. So this one that will not be shaking from is not, listen, you find out that when you do the mathematics, it will fail because that 14 day is not constant. You won't know where to place it, whether it will not come after 24 days or it will come at 30 days. That is the issue. Then the lactational amenorrhea, where the woman breastfeeds, and because it's breastfeeding, the feedback mechanism to the brain will not give hormones that will not release ovary. So there will be inhibition of ovulation. So lactational amenorrhea will come, there won't be any menses and there won't be any ovulation. Cervical mucus and this spine bucket is well known to all of us. The emphasis in terms of when we have listed all these as the methods and I've given some bits of explanation on each of them, the one that is commoner we are noticing these days, we have been noticing, is charm, strength, rituals, religious prayers, incantations, concussions, and even the tattoo and the scarification, not tattoo, scarification mat. Tattoo is for beauty. Scarification in medicinal. Even scarification mask. All these are, now, if you look at all these, you see that there are still many methods that are traditional and many people are using it. You see, there's an explanation I gave you earlier. Don't ever be thinking that you are comfort as we are talking to each other. That's how no. We are considering just very small percentage. Or you say, well, who is using traditional? That's the question you ask me now. Who is using traditional? My sister, my brother, so many people are still using it because 95% of people are still on that level of lower range and they can delve into it. And you won't blame them. The important thing that you have known about them. And the problem is that in terms of whether it's under the woman's control, it's not actually under the woman's control per se. The ones that are under the woman's control are those ones that are proven that when you put it inside the womb, like IUD, for 12 years, they are covered. When you put it under the arm, for 3 years, you are covered. This is under their control. When they put it there, so at times they forget to come even remove it when it's expired because they are forgotten and live their life and move on. So that is it. And the failure rates are higher because it's not scientific belief. For example, you don't know the quantity that was released. The person that doing incantation for you don't know how strong the dibia is. The person that is putting a scarification mark, you don't know whether he used the correct chemical or the expired one. Even he that is using that chemical doesn't know that whether that chemical is well measured. But if it's scientifically based, it has been tested in the lab. See the quantum and quantity of something, that the chemical that is there. It is accurate. So the chance of failure, the failure rate will be known. Now, because it's not quite hygienically acceptable, it's not that popular. Like the girl, that person I told you, a fine girl, put leave inside there. Yes, is the friend in the school that taught her that he worked for her and he's using it. And I asked her, since you are busy, he said that he has not gotten pregnant. I said, okay, I kept quiet. That's what it's from. My parents established that there was leave inside there and it's used for contraception. Going to prove that traditional method is still there. So more cumbersome to understand and apply, which is the truth, as I said. So difficult to standardize. And this, since you can't standardize, as I've been saying earlier, you can't say for sure that this is what you can do. So we can't guarantee the potency. That's what I'm making. So second to the last slide is talking about sex selection and methods. So we have methods of sex selection, as I said, trying to select sex. Which one do I want and which one that one? We have pre-implantation genetic diagnosis. You can't say for sure. But then when it is done, the chances of accuracy is about 100% accurate. That is to say, before implantation, either through IVF or natural, there's a needle biopsy kind of thing. The problem is that such procedure can lead to miscarriage on its own. But then sample is taken where genetic diagnosis is made to know whether all is well and whether is the sex wanted or not. The question of if you don't want it, what do you do? Do you go and terminate? Becomes another issue for you and your conscience and arguments. That's by the way. So the very popular one these days is EC, intracytoplasmic sperm injection. That is to say, during IVF, you collect the X chromosome, put it on the slide, collect the Y chromosome with that needle, special needle. I'm not into it, but I'm telling you how it is, and that is what it is on broad discussion. And they inject it directly to the X chromosome so that then they can fertilize and the zygote that is a male can come, since it's X and Y. If it's female that are looking, it becomes X sperm and then S garment female egg to get what they want. It's still the same thing. Then chronic valence sampling can be done before implantation using an ultrasound to discover accuracy, to discover the sex, and its accuracy is poor. But then it's also done. And the question also remains, ethically, what do you do? Assuming it's not the one you wanted eventually, what do you do? Do you terminate the pregnancy or does she go ahead with one? Is a case for another discussion. So natural selection, which is part of sex selection, the other one is scientific, but the other one is natural. The main thing about this natural selection is without artificial assistance, is that we know, listen very well, we know that Y chromosome is fast, it swims very fast, but dies very fast as well. The S chromosome, which is forming the female from the sperm, the first thing we said is that the sperm Y chromosome swims very fast but die fast. The second point we're making is that the S chromosome of the sperm, because sperm have X and Y, while the egg have all X. Now, the S chromosome of the sperm doesn't swim that fast, but it stays longer, like even 3 days, 72 hours. Now, it then means that if one wanted, mathematically, it's not as if it's the chances, it's not as if it's predictable in science at being accurate. It's just something you feel that might be better. It then means that if one wanted a male child, you try and have intercourse at ovulation. If you can pinpoint your ovulation day or time, hit the sperm, it swims, Y chromosome will swim very fast and go and fertilize the ovulated egg immediately. So the chances of having male child is there. So that is the mathematics that it wins fast and die fast. So once it doesn't hit and get it, it means that the X chromosome that will come later and now stay there for about 3 days, we take off the thing and becomes, and that's maybe why the female gender is higher, because of the resilience, of the doggedness, of the persistence of the XY chromosome, and that forms female. Female are usually dogged in everything. They keep quiet, and when it's time, they take what they want. They talk. So, national population policy is a set of guidelines and strategies a country uses to manage its population growth, as we have said. It depends on how we want it. So in that welfare, we talk about education, health, improved quality of life, demography, and planning. So the guideline will follow all these protocols, especially as tailored from the family planning policies as well, to make sure that things go the direction it is wanted. In Nigeria, the National Population Commission coordinates the activities of the national population guidelines and strategies to make sure it achieves the Nigerian national population policy. And that is the way it is. To reduce in Nigeria, I think this policy is, I think, 2024. I didn't check up this 2005, to be honest, before this discussion. But I know that 2003, 2004 have the same policy. In fact, for what I noticed in the past, studying the policy, just glossing through the policy in the past 10 years or so, I noticed that the change comes after about 2 years. So there must have been a change now, because the last I know is 2003, 2004 saying the same thing, which is that our fertility rate is about 5.8, 5.1, I just guesses up and down, but I think on the average around 5.6. 5.2, sorry, around 5.2. And the aim of those 2 years population policy, the population trust, the way we're heading, the strategy and guideline is heading towards, do we bring it down to about 4? Meaning, on the average, every woman in Nigeria should have 4 children, on the average. But this average thing is not easy, because as you are planning, because just like I keep telling you, and that's what the thinking I want you to inculcate, that when you're talking to people, also make them understand, because that's the problem we have in Nigeria. It's one of the main problems whenever I go for this kind of advocacy. They will use themselves as a yardstick, as a measure of what you are saying, which is very wrong. As I'm talking now, if I have not been emphasizing what I'm saying, so if people say, what is this man saying? Almost every person, they have 2, 3. It's okay. You forget there are many people that are having 10, 11 that you don't even know. Which one consign them? Every year they drop 1. So we're talking about average now. So that those people that are dropping 10, 11, or 8, let's say to be more serious, 7, 8 everywhere, that by the time you have 2, or something like that, when you take the average, it comes to about 7. And that is what we are talking about. And by the time you talk on all these things, you get what you want. So the strategies and guidelines going to achieve all the things I've said, you look at reducing fertility, if that is the case. If there's no case that all our women are healthy, well, all their children are healthy, well, the means of enablement and training them, and the feeding and the housing and clothing is there. So here with anything, there can be 1 million, but the policymakers have looked at the hands that we feed and the mouth is going to feed, and found that there's need to bring it down a bit. That's, to bring it down in terms of policy advocation, not forcing any person. But if, for example, we're in China and everything is there, maybe our policy might be to achieve 10. So it depends on the country. That's what we're saying. It's a country policy, strategies and guidelines, depending on the ecosystem around them and how to now balance it in order to make prioritizing women's health and promoting secondary education. So the objective, as we said, is to increase this thing. So my sisters and brothers, that's where we come to the end of our discussion, and we will take maybe just one or two, let's say highest 2 questions, and we'll go. Thank you very much. You can see my summary, my conclusion, my acting words. I thank you. I thank the NGOs that have invested so much in me and in many other people to grow in this trust. Thank you.
Thank you, sir.
Thank you, Prof. Thank you, sir.
Thank you, sir. Good night. Sir, good
Thank you,
night.
sir. Good night, sir.
Yes.
Thank you,
Thank
Prof.
you, sir.
Good night.
Okay, I will send this to your class rep.
Thank you, Prof.
All the best.
Yes, sir. Help us with the slides, sir. Thank you, sir.
Yes, I will send it to your class rep.
Thank you, Prof.
Thank you, sir. Thank you, sir. You're the best.
Thank you, my boy.
Thank you, sir. My Chief Oranu. Good evening, all. Let's go.
Thank you, sir.